course. My name is Roger Rivera, psychiatric nurse practitioner, doctorally trained, with specialties in family practice or FMP. Come from a lineage of trauma surgery and now serve as an educator as well. Yes. So before, and honestly, the biggest takeaway here is going to be stability first, right? So clinical factors, right, for GLPs and stable patients. I mean, so clinically, what I've seen time and time again, especially with serious mental illness, clients are already facing, a dramatic reduction in their life expectancy and just overall quality of life. Much of it is also driven, especially if they've been going through this for quite a long time. A lot of that could be driven by some cardiometabolic disease or illness. So, it's exciting that we have the GLPs, and the core message around that is just going to be with anything that we do, do no harm. This is a whole team thing. And that's where, yeah, I would always say, don't destabilize someone who just got well or someone that's been well for a while. So first it's, confirming, like I would tell any student or just any colleague, as we discuss changing any medication. All right. For whatever reason, right? Let's say I have metabolic compromise. All right. Then maybe we should discuss what the best approach should be. But first, in the context of stability, recent hospitalizations, we want to look at, when's the last time that we had mania? When's the last time that we had any one of these prevailing episodes? Has there been an issue with medication non-adherence? That's another key component. Is there active substance issues, any anxiety, any overwhelming comorbidities, or the other symptoms that are still overlapping? I see thousands of clients, and help the students sometimes. Sometimes they're so inclined. Just to give one small example, we're so inclined to make a change immediately on a regimen, but not every stable patient is truly stable. So, sometimes stability is recent, it's fragile, or it's heavily medication dependent. So those changes have to be very minute, and very independent to that individual. So just looking at, then the other thing you want to look at is regimen complexity. How long did it take us to get stable? If it took us 4 or 5 regimens and now we're stable, oof, are we on clozapine, were we on combination of olanzapine with something else, Lybalvi with something else. So yeah, and then of course, lastly, I would say behavioral vulnerability. You know, um, yeah, and this is where's the individuals? I always say, of course, we try to help our clients and guide our clients in that direction where, it's not just the medication doing all the work. It's doing some lifting, but you as the individual have to, hydrate, worry about your nutrition, the physical activity component, stimulant overactivation, all this other stuff. And of course, most importantly, medication adherence. So I'm glad that in psychiatry now, we're talking about integrative psychiatry. We're incorporating appetite, sleep. It's not just a trivial, it's not just a cookie cutter approach to treat anybody, right? We have to look at all these biological functions. So the concept here would be a core concept here would be psychiatric recovery and metabolic recovery should not compete against each other. Now we're at a time where we do have, right, newer agents in the transgression of my career so far. I come from trauma surgery first, and then I got into psychiatry. And for years when I got into psychiatry, we were still using more archaic regimens, right? I mean, whatever we needed to stabilize. So for years in psychiatry, we were forced to have a painful trade-off, mental stability versus metabolic health. And this I like ideally, in the future is not choosing between the brain and the body. Now it's let's choose something that off the bat I could, continue using without having to go into this metabolic compromise. Um, so what I've seen in clinical practice, and this is time and time again, trying to stabilize, first psychiatric break, second psychiatric break, time's a ticking. The gray matter is, very important, for a lot of things, for the salience mode, default mode, everything else. So, the more compromised it gets, the more, the more time to take. And so we want to stabilize. Um, and then we also don't want to destabilize either. But then at the same time, we're going up against, metabolic compromise. And that's where, we want to preserve the effective psychiatric regimen whenever possible. it's important that we monitor, right? Avoiding disrupt or abrupt discontinuation of a psychiatric or a antipsychotic solely for weight concerns, that boots on the ground perspective. I mean, everybody has thoughts on that, right? I always say once disability is there, just like we said, we want to look at all these other parameters. But I still have colleagues that are of the, I was at an advisory board for a major pharmaceutical or for a company that we were working on bipolar disorder. And so I was the only outpatient or predominantly outpatient guy. We had a lot of inpatient guys. And I was like, yeah, if there may be a few years of stability, I might think of reducing that. You fill in the blank, whether it was high dose risperidone, high dose clozaril, yeah, right? Because they were talking about inpatient, they were talking about the most acutely more acutely ill patients, and they're like, no, I would never touch that molecule once. And these are practicing psychiatrists of many many years. So it's understanding that we continue to understand about that brain. So a patient losing weight but relapsing psychiatrically, that's not really a successful outcome. So that's where it's like weighing it, where if we used to say is like in pregnancy, right? Does the benefit outweigh the risk? But when done carefully, and that's that part, right? Which is proceed with caution. Anything that we do, do no harm, go back to the basis. But when we do things, but when done carefully, I think, some patients experience meaningful, not just improvements in self-esteem, but mobility, inflammation, energy, engagement and treatment. I've seen this firsthand as well with GLPs. So first off the bat, this is where pharmacists are often the most underutilized early warning system in mental health care. My pharmacist here in the community, I'm in downtown. With downtown Kissimmee is where I predominantly practice. My community clinics, I mean, my community pharmacists, these are the guys that help me. They're on top of it with the refill delays, right? Adherent shifts, all this other stuff. So when it comes to particularly with, um, as we're making that shift, the pharmacist is going to be aware of, nausea, vomiting, sedation changes, appetite shifts, which are going to play a significant role in the psychiatric component. Patient confusion. Is it really confusion versus, oh, shoot, we had a patient that had a diagnosis of bipolar disorder or schizophrenia. And now, as we're making the change, we're starting to see this. So emerging side effects as well. They see this all before we do sometimes. A lot of times, and let's say it's a weekend, and same thing, local pharmacist is going to be more available sometimes than the outpatient guys. So, and they always, I love the fact that, of course, they're always going to be, giving them keys of or key signs of destabilization. Not just explaining it to them, but also observing for the insomnia, the activation. These are clients that typically have, um, a lot of other medication as well. We talked about the metabolic compromise, and unfortunately, what we see with a lot of these conditions, these prevailing conditions, such as bipolar and schizophrenia, we have individuals that have comorbid primary care illnesses as well. Not just the metabolic kind, autoimmune and all these other components. Talk about the mind body connection. So yeah, when you're making a change like this, you might run into, more agitation and worsening anxiety interactions that they're also seeing as well. Um, cognitive slowing, dehydration, and fatigue. So a pharmacist may notice the beginning of destabilization way before it becomes a psychiatric crisis. And it's just being aware. Um, that's where a lot of times they'll see that client a couple times during the week picking up their medication. So the best outcomes happen when, it's a collaborative approach, not just the mind body, but also collaborative in primary care, endocrinology, pharmacist, um, and the pharmacy, communicating instead of just operating in silos. This is where I noticed that, my pharmacist helped me with, like I said, a lot. Sometimes I reach out to them first, right before I make some of these decisions. But it means treating the human being. At the end, means treating the human being, not chasing a number on a scale. Um, a lot of times we're so reactive in psychiatry. I mean, well, I come from trauma surgery, so when I got here, I learned not to be so reactive. I learned to, a lot of times trauma surgery, you come in, we want to fix. Emergency medicine, you come in and want to fix. ICU, you come in and want to fix. We're looking at these variables, at these numbers, at this data. So same thing happens here. Not chasing a number on scale is the same thing as regular outpatient practice, also not chasing the PHQ-9 and GAD, right? Yeah, we want patients to not have a overwhelming PHQ, but we also are not going to expect it to be at 0. So, um, every individual, every client, looking at what that looks like for each individual, um, that would be weighing, risk benefit analysis, as well as something that, we often, that as clinicians, we have been doing it more and more, but teaching it, but informed consent, asking your client, having them, if they're involved, if they could be involved. Sometimes it's a little bit more difficult depending on the illness, but gradual titration, that's imperative, right? Um, Not everybody is gonna react the same on the same dosages. Um, that I've seen this, depending on it with the metabolic pathways involved, other chemicals involved, right? So we want to see what that looks like. Um, then that's, the whole adage of start low, go slow. I have clients where, all of a sudden, wait a minute, that low just turned into even lower. The other thing we want to look for is make a treatment plan. Um, for this for all our individuals. That's, a game plan. What is our goal? What does that look like? Um, then I'm back to the pillars of life too, or the physical activity, um, the nutritional intake, not just the chemical component, and then of course the sleeping. But yeah, so realistic expectations. I work collectively with, of course, therapists and all sorts of therapists and all sorts of clients. And you know, every client's need and expectation is going to be different depending on what their baseline was, depending on what got them here. Everybody's mental health journey is different. So, just preserving that psychiatric continuity, but in a balanced manner. But because we have to reduce the barriers so patients can access that treatment safely. Period.